Good morning, everyone. I'll start with my presentation with this diagrams, which shows the recurrence of epithelial ovarian cancers. And it's very important when we treat and the patient, when they present with the recurrence, we have to know in what place and what time she recur after the chemotherapies. So you can see here, about 5% of the patient, they actually progress during chemotherapy treatment, and which is called refractory types. And these patients usually do the worst. So the earlier the recurrence occur, the worse the prognosis. And the later the recurrence occur, better diagnosis and multiple or many options of treatment. So the refractory type of patients with the one that recur within 6 months, it's called platinum resistant. And most of these patients, either they not have or the surgeon was not able to do complete cytoreduction, or if they were in neoadjuvant treatment, they don't usually respond. They have either partial response or no response at all. And I think this goes with the theories of the tumor biologies. The other type, which is the platinum sensitive patient, the patient that recur between 6 to 12 months, and it's goes with platinum sensitive group, but it's partial one. And these patients usually respond to platinum initially, but later on they will have again recurrence and recurrence till they develop the platinum resistant. Another type, which is usually recur later than 12 months, and these patients that do actually better than the other groups, and we can offer them many type of treatments, including surgical resection if they are or if they have good selection criteria. Again, when the patient present at the diagnosis primarily, our aim always for cure. And about 17% they actually has no relapse after 10 years. But when the patient present in the recurrence, so always our aim for the treatment is quality of life. Again, so very important when the patient recur, we have to state the patient whether she's in refractory or resistant, or she's platinum sensitive group. And you will see there's a different type of treatment in each groups. And this is the factor impacting the therapies. Comorbidity of the patient, performance status, disease volume, and prior toxicity to the chemotherapy that she used. Also the drugs related factors, which is efficacy, scheduling, and toxicities. Tumor factors, it's very important, the therapy interval, free interval, and resistant status. So the first group that I'll talk about, it's the platinum-sensitive disease group. So the option that we have, it's surgery in selected cases, single versus combined therapies. Rarely we use radiation in these cases. Psychosocial support and clinical trial eligibilities. So, as I mentioned, the later the recurrence, the more option we have. And sometimes we deal with them like as they primary presented. So, what we usually do in our units, we review this patient in our tumor board, whether she is for cytoreduction or chemotherapies. We use certain criteria, which is the platinum sensitive patient interval, recurrence, single site, performance status. Also, we have to make sure that we have all the facilities, which is ICU, instrument, and also surgical teams. If the patient, we decide not for surgical resection, then these patients usually do much better with combined chemotherapies rather than single agent. And here the studies showed that both progression-free survival and overall survival better in combined therapy, platinum with paclitaxel or platinum with gemcitabine. Again, we have to put in our mind the side effect, mainly the neuropathies, which shows with if you go with platinum and paclitaxel, you will have more neuropathies than if you combined platinum with doxil. Again here, the different trials that showed the combined therapies, it's better than single agent. The trial, it's not clear here, but both European Icon 4 and the GOG studies, it shows both the progression-free survival as well as the overall survival. It's better in platinum-sensitive patients group. So, what about targeted therapies for platinum-sensitive patients? We have now two types, which is the angiogenesis inhibitors or PARP inhibitors. How these medication works, the angiogenesis inhibitors work in actually the VEGF, the intracellular blood vessels, which is inhibit the VEGF and cause or decrease the angiogenesis to the tumor cells. And this is the study which was presented in ASCO 2011, comparing the Bevacizumab with chemo compared to the chemo alone. And the studies actually showed, which was randomized, phase 3, which shows these patients' progression-free survival did better than the chemo alone. So the hazard ratio was 0.48, and the progression-free survival was 12.4 months compared to only 8.4 months for the chemo alone. Also, the response rate, as well as the complete response rate for the Bevacizumab group, it shows better than the chemo alone. But unfortunately, for overall survival, there was no difference between the two groups. But again, quality of life and progression-free survival, it's very important in the ovarian recurrence. What about PARP inhibitors? Again, the mechanism that the medication bind the PARP, so prevent repairing of the DNA of the cancer cell, and that's what led to cell death. And Dr. Tom Herzog, he will talk about the PARP inhibitors after this lectures or this presentation, and also we will have the satellite symposium regarding the PARP inhibitors. And again, the SOLO2, which was presented in SGO 2017 for the mutated BRCA1 and 2 ovarian cancers recurrence using the medication compared to the placebo as a maintenance therapies, and which shows a little side effect in demographic patient with mutated ovarian, epithelial, or fallopian tubes using 2 or 3 lines, and the platinum sensitive group between 6 to 12 months or more than 12 months. And this is the progression-free survival with hazard ratio 0.3 and p-value 0.001. The olaparib or PARP inhibitors group progression-free survival 19 months compared to 5.5 months for the placebo group. Using the blind reviewer, it shows actually it's better, that progression-free survival, it's at 30 months compared to 5.5 months. And so when we have a patient who's platinum sensitive recur after 6 months, and that's actually, it's easy to summarize. So we have to decide whether this patient surgically selected group can go for surgery or chemotherapies, and always we use 2 chemotherapies, platinum and other. And if the patient not used VEGF medication or Bevacizumab, we add Bevacizumab. And if the patient BRCA mutated, we start the PARP inhibitors after the chemotherapies. What about the other group, the platinum-resistant disease? Surgery rarely indicated. Single versus combined therapies we use. Radiation in isolated cases. Psychosocial support and clinical trial eligibility. It's bigger option for this patient sometime. And this is the phase 3 studies, which shows different type of chemotherapy, non-platinum chemotherapy used. And you can see the poor prognosis, that progression-free survival, most of them average, it's 4.4 months. And overall survival, it's about 12 months. And this is, again, it shows that no difference if using single agent compared to double agent. And there's different studies prove it. What about VEGF or Bevacizumab? Again, and I think this group, everybody agreed here that to use the Bevacizumab in this group, it's better choice than maybe platinum sensitive, because we don't have too many things to offer them. So again, Bevacizumab in this group showed again the improvement of progression-free survival, and with the hazard ratio 0.4 and p-value 0.001. Again, it's also showed good response. So, and this is again to summarize the platinum resistant. So, to decide whether this patient, is it for chemotherapy, she can take chemotherapy or not, no, then for supportive care, or if she's for chemotherapy, then to choose single agent. To add Bevacizumab is a good option for this group. So in conclusion, most of the epithelial ovarian cancer recur. Treatment depends on tumor-free interval or platinum sensitive or resistant. Combination of therapy in platinum sensitive is the treatment of choice, cytoreduction in platinum-sensitive selected cases, monotherapy in platinum-resistant is the choice of this group, targeted therapy, especially PARP inhibitor, demonstrates significant progression-free survival in a platinum-mutated sensitive patient. Thank you.